Good morning, good afternoon, good evening, good night, friends and colleagues from all around the world that are tuning in. We are starting our session today with a special guest, a friend of ours that many of you know, Dr. Pavel Krastev. Dr. Pavel, thank you for joining us today.
It's my pleasure, Dr. Shah, and it's a pleasure to be a part of such a great program that you guys are operating across the globe, and I'm very proud of you guys. And what can I say? I'm humbled and very honored that you guys are giving me this opportunity with Dr. Kayvan.
You're very, very welcome, and we would like to start by kind of giving our audience a little brief introduction to you. First and foremost, two metrics of interest. We are almost at 800,000 professionals reached, as well as across the 10,000 like mark on our Facebook. And we have saved a lot of good speakers for the last, and you're one of them. You're a protege of what a dentist could be like and what kind of a career a dentist could have. A family man, an innovator, a practitioner, a lecturer. You have a background from Bulgaria and Armenia, and are now in the United States, taking care of patients on a daily basis and changing lives. But before I wanted to mention that before I actually read your official CV here, your bio. So Dr. Pavel Krastev, DDS, graduated from New York University in 1993 at the top of his class. Admirable. Pavel was appointed as assistant professor in Kappa, where he served for 2 years while establishing his private practice. In 2004, he completed his 2-year implant training at NYU. Upon completion, he was invited to stay on board and serve as a clinical assistant professor in the 2-year continuing education implant program from 2014 to 2016. Over the last 6 years, Dr. Krastev developed and patented multiple dental products currently on the marketplace. Pavel practices dentistry full-time in New Hyde Park, New York. In addition, Pavel works closely with Helmut Zeff, GmbH, the German version, as a KOL and development partner. As a fairly recent, Pavel has developed a passion for PRP, autologous blood concentrates. This passion was originated by his mentors and models, and it started with going to conferences and visiting different companies. Now Pavel has a new passion for exploring fully the world of PRP. In his spare time, he takes flying lessons and is pursuing his lifelong dream of being a pilot. By sharing our knowledge, we grow ourselves, he says. It's all about love and passion, loving what we do and doing it is with a passion. So, Dr. Krastev, you're flying around too, huh?
Well, I was flying around about 2 years ago, and then I kind of said to myself, I have 2 small, beautiful kids, and I got about 30, 40 hours under my belt, and I was about to solo, and I said to my instructor, dude, I'm not ready to solo. So I haven't soloed, and I probably will go back this summer if things change a little bit with the climate here, with what's going on currently in the world. But that's something definitely in the background right now. I'm focusing on my products and on teaching and educating people on the VGO system, which is obviously my passion. And I'd like to make a couple of disclaimers here so people know a little bit about me. So as Keanu, Dr. Shah mentioned, I am a KOL for Helmut Zeff. And I want you guys all to understand that I do get small royalties on my products that Helmut Zeff sells. But what you will also notice, folks, is I often post many things from Helmut Zeff on my timeline. I share it to some groups, and I don't get paid whatsoever for doing any advertisements, for sharing products that I enjoy using in my practice. So I want you guys to be clear on that. I don't sell instruments directly. I'm a dentist. I'm a clinician. I treat people all day long. So pretty much I like to basically share with you guys what I've developed. Today we'll be focusing on the VGO product a little bit. Not in too much theory detail, but we'll go through a few interesting cases. And I selected some rather interesting cases in the sense of what some of the younger guys maybe perhaps can learn and take home. So I avoided putting trophy cases. I'm putting interesting cases, I think, that we could all learn from. All right, guys, so I want to clarify that. And Then at the end, we have a very small little surprise for everyone from Helmut Zeff, Mr. Heinz Leben, who's the general manager of the company, basically runs the company. He made a very quick offer to me yesterday that I couldn't refuse. And, you know, there's a little courtesy extended to Dr. Shah and Dr. Kevan in Global Summits. And we'll throw that on the screen at the end. It'll be a, maybe you guys will like it, maybe not, but we'll show it at the end.
Wow, that's quite admirable that you do all your disclosures before your presentations. I think our colleagues will appreciate that. And today's topic, Dr. Krastev, the VGO man, the only VGO man, the maxillary osteotomy formation. With that said, our dear friend, you shall have the floor.
Thank you. Welcome, everyone. I hope all of you are doing well during this difficult times. We've all come together as a profession and as friends and as colleagues. And I just hope that all of you are safe and getting through these difficult times. And everyone is doing their best to do these webinars. And Dr. Shah is very kind enough to spend much of his time in formulating all these events. So really, it's an honor for me to be here with all of you guys and colleagues and friends, and let's have a little bit of fun, okay? So now the presentation. 1 second, because I can't see the presentation on full screen here. Dr. Shah? Ah, here we go. Okay. Now, how do we make this full screen? Hold on. We're having a little issue here with.
You can click the open full screen button on the lower.
No, but I can't. Hold on a second here. Why isn't this full screen?
You can go to when you're in your PowerPoint. You can click the.
Oh, how is this? Does everybody see the presentation now?
Yeah, we see the presentation, but it's not full screen yet. The presentation is in the background. You may want to click.
How about now?
Yes, perfect.
All right. Sorry, guys, for the little confusion. So, ladies and gentlemen, colleagues, one thing that I want to always start with is implantology is a very challenging field. And one thing that many of us sometimes tend to forget is that all cases must be prosthetically driven. So prosthetically driven allows us to plan our cases and essentially provide our patients with some data as to what their face and structures will look like after the cases are complete. And by doing prosthetically driven implantology, we are essentially planning our placements and the reconstructions ahead of time with diagnostic wax-ups, with certain duplications of setups, etc. And then we position our implants properly, and then we restore our cases properly. And one thing that I like to talk to the younger guys with less experience about is when we have a case. Let's assume a case comes in and there's abundant available bone, and the first thing we look is, wow, what can we do full fixed? Well, in many cases we can do full fixed, but if we do full fixed and the case is not properly planned, then the patient will come back to you with a mirror a week later and say, guys, I love everything. I love that I cannot take off my bridge, and it's terrific, but look at my face. I don't have enough support on my lips. So in many cases, folks, even though that we have abundant bone, full fixed may not be the best option, and a better option that will provide more support may be a removable appliance. So all I'm saying is all cases should be properly planned. All right, guys, so let's move on. So this is a beautiful case. And again, this is not my everyday reality. Different patients present to us with different anatomy, with different structures in their mouths, with different soft tissue configurations. So, do I achieve this kind of success with every case? The answer is certainly not. Is this my everyday reality doing full mouth reconstructions? No. I'm a general dentist. For me, my bread and butter is a single implant, 2 implants, 3 implants. All right, and the VGO system, folks, as we'll talk about in a bit, is really designed for the. We have an anterior kit and we have a posterior kit, which we'll review briefly. But today I'll be focusing mostly on the anterior kit, which is designed to be used in the aesthetic zone, and when access permits, it can be used also in the premolar region, and in some cases even in the molar region. All right. So when I have a patient, I always spend an abundant amount of time discussing, having essentially an interview with the patient. What are their desires? What do they want to accomplish? I evaluate their smile line, their soft tissues, their periodontal condition, and then I sit with them and I discuss what is really feasible to expect. And I never give guarantees, and it's a dialogue we have with the patient. And I see way too often in my practice, patients go for consultations to many practices, and they come back to me and they say, well, this is what they told me. This is what they told me. No one explained anything to me, and I really don't understand anything. So I think a dialogue is extremely, extremely important. So the wedding story I'm going to skip here for the benefit of time. So the VGO, as you guys can see on the left side of the screen, this is the anterior kit. And if you notice, the tips are threaded to the 8 mm mark. Okay. So the VGO is a system that's universal, and it can be used with any implant system. I have gotten many questions in the past that people asking me, well, what implant system is this? And it's not an implant system, folks. These are hand dilators, okay? They use a rather different formula of the tip escalation, which is a step formula. And hence, this step formula allows the VGO tips to enter the osteotomy passively to a certain point, and then dilation begins. So in other words, the VGO system eliminates and rather diminishes the crestal stress that occurs when traditional taper osteotomes are used, because traditional taper osteotomes have a mathematical problem. And when they are not used to full depth of their working tips, you end up essentially trying to shove something with a cross-sectional diameter bigger into a hole left by the previous osteotome that is smaller. And that's how we start to break the bone. So we go around this with our patented taper. All right. And again, hand rotation is important because we can control how fast or how slowly we dilate the osteotomy. All right. Different bone densities will require, in my opinion, a different management. In other words, when we drill, we are not addressing dense bone versus soft bone. We are just drilling and removing bone. Okay. And in addition, with drilling, we're generating heat. All right. And in many systems out there that spin backwards and forwards and backwards again, they end up burning the bone, in my opinion. And temperature, as I think we all agree, is not well tolerated by implants, although it is tolerated to a degree. All right, so the VGO system, folks, we always start with a pilot hole, which is pilot. I mean, I'm going to call the osteotomy hole for the sake of the presentation, just to make things a little simple. So we make a pilot hole with any one of your pilot drills that are standard in your whatever system you use. So there will be some variation in the size of the pilot hole you create to full depth. And when you have the available bone, I always recommend making the pilot hole 1 millimeter or 2 deeper than the intended implant, so that you can countersink your implant if that's what you wish to do. But be careful and cautious, because certainly we have to respect structures, sinus floors, etc., and focus whether we can go the extra millimeter or 2. All right. So varying bone densities, as I said, require varying rates of dilation, and this is why I have been obsessed with manipulating bone when I can by hand, because I can tell how fast or how slow dilation to occur. In a very hard bone, I proceed slower with the expanders. In soft bone, I go faster. Okay, so there's a learning curve, and it's important to understand how the concept works. So the VGO, as I said, is not a subtractive process. Once you do the pilot hole, which I'm showing right here in the with the yellow line, and I overextended it a bit if possible. Now, I'm showing a lower jaw here, guys, but the VGO, I want to make this clear. I'm showing a lower model here, but the VGO system is designed to be used in the maxillary arch. Okay, it's not a product to be used in the mandible. All right, folks. So it's not a subtractive process. We're not removing bone. We start with the pilot, and then we start with tip 0, tip 1, tip 2, and we expand the osteotomy until we achieve a size that is smaller than our intended implant, of course, because as we all know, we don't want to have a spinner. If we have a spinner, there's ways around it. I do certain tricks, which I'll maybe address in a different lecture. But we generally want to undersize the osteotomy, okay? And that's the same concept even when you drill, we undersize, all right? And one very important thing I'd like to mention is I always prefer to start placing my implant and have it torque out too early and back it out and slightly open the osteotomy a pinch more, as opposed to me overblowing it and then having to deal with the spinner and possibly having to go to a wider fixture if possible, all right? So those are things we must take into consideration. So when we expand following the pilot hole, what are we accomplishing, guys? We are densifying the bone. And typically, as we all know, in the maxilla, we very often have type 3, type 4 bone. And when we drill and we remove bone, essentially, you're not really densifying, okay? But when you start with a pilot and use dilators, you are improving the bone quality. So very often you might go from type 4 to type 3 or from type 3 to type 2, all right? So again, as I said, the VGO is designed for the aesthetic zone and the premolar region, the threaded tips, okay? The posterior kit, of course, is designed without threads, and we have an angular component because in the posterior, as we all know, osteotomes cannot fit because of access reasons, all right? So, but even though when we use the posterior kit, we still have the advantages of the passive entrance and the advantages of how the tips operate in terms of the bone dilation. Okay, so the both anterior and posterior kits, they have the exact same concept. Okay, and the exact same, they work, except the anterior is threaded, as you see here, to the 8mm mark right here. Okay, and the posterior is not. So some malleting is required with the posterior kit. So as I said earlier during the introduction, I'm a general practitioner, and my bread and butter is single implants, 2 implants, 3 implants. You know, do I do full mouth cases? Absolutely, but that's not my everyday reality. So the VGO, I think, is a product which can be used obviously by oral surgeons, periodontists, general practitioners, but it's a product that has benefits for particular areas of the mouth. So we published on it recently. I forget which month was the publication. January. That was my first publication that I was very proud of, and it was just a different kind of honor. So why do I say VGO and endodontics? Well, if you guys remember back in dental school, when we learned endodontics, they used to teach us the step back technique, and you step back, you step back, you step back. You create ledges in the canals, and then you meet the ledges, you marry them, whatever you want to call it, and then you fill them. Well, today we do endodontics with rotary devices, and certain systems allow you to instrument one portion of the canal without affecting the other portion of the canal, and vice versa. So the VGO works in the same premise, okay? We have 2 types of tips. We have delta 1 tips and delta 2 tips, and they both work at equal and opposite poles of each other. All right. Now we're going to see the tips in a minute, but what I want you guys to understand is delta 1 tips have half the taper of delta 2 tips. Okay. Delta 1 tips will dilate only the deep bone and not do anything at the crest, and they have a narrower taper. Delta 2 tips are the more aggressive tips because they have double the taper of the delta 1 tips, and they dilate the crestal portion. So when you're using the delta tips, which are a little bit chubbier when you look at them, you have to exercise more caution, because as we all know, the crest is usually the thinner portion. So if a delta 2 tip is working on the crest, we have to be more diligent with how we proceed and a little slower. All right, so as dentists, you know, and I always say this, and I love saying this, I think we're all microscientists. We work in a very small environment, and in that small environment, we find smaller things to work in, and then in there, we find even smaller things. So, you know, most of us are talented enough that if we were stuck on a deserted island and we face a situation where, you know, someone loses a tooth, I think many of us can do an osteotomy even as with a device as simple as a nail and a hammer. Okay, but we treat patients. Our patients have feelings, they feel sensations, and we use products that essentially are designed for medical purposes. So we don't use nails, okay? But we are talented enough that we can do all kinds of procedures, and, you know, we know that, okay? So today we'll be looking at a concept where we'll be focusing on how we handle that hole. How do we manage it? What happens? What are some of the benefits? Okay. As I said, there's no perfect product, and this is from Shark Tank, from Mark Cuban, and he always says every product has limitations, and this is certainly also the case with the VGO. All right, so I'm not making any claims that this is some kind of magical product designed for every single case, magic for all one solution. No, that's not the case. This is a special system designed for special cases, and once you get to learn it, and you can grow with it. Okay, so let's look at the anterior kit. The interior kit, we have tip 0, tip 1, tip 2, tip 3, tip 4, tip 5, tip 6. Okay. If you notice, the threaded portion ends at the 8 millimeter mark. All right. So these threads, folks, once you do your pilot osteotomy, and then you start progressing from the first to the second to the third, to essentially to the size that you want to accomplish. Okay. And then you place your implant. So these threads drive the instruments into the bone, number one. Number two, these threads create microserrations in the bone, and microserrations will increase bleeding. And as we all know, bleeding is a good thing because bleeding has what? All kinds of good stuff that's in blood, platelets, degranulating, okay, growth factors being released. So that's a good thing when we see blood in an osteotomy before we proceed. Okay, if you note, there is a little dot above here, in this case below, above, below, above, below, above. So these dots, folks, indicate which portion is active. Okay, so a delta 1 tip, as I said earlier, let's look at tip 1. The dot is below the number 1. All right, so that's a delta 2 instrument. Okay, if you look at the first tip, it's labeled tip 0, and the dots are above and below. Why? Because we believe that the pilot osteotomy will vary in size based on which system of implants you use. So there may be some discrepancy between the pilot osteotomy I create with my system or another doctor that uses a different system might make the pilot a little bit deeper, or a little bit, not deeper, rather, a little bit bigger in cross-sectional diameter, or a little bit smaller. All right. So we have put 2 dots above and below the 0 on the first tip, which is tip 0, to indicate that the tip will act based on the size of the hole created. Okay. So and I'm just showing the posterior kit here, and I'm showing the wave, as you guys can notice here. And this wave represents exactly what happens. So this osteotome will dilate the crestal portion. The next one will only work inside the deep bone, okay, and not do anything in the crest relative to this instrument. Then the next one will dilate the deep bone, the crestal bone, relative to this previous instrument, and so forth, okay, until you get to the right size. So some of the key points: you can use the product for bony expansions, for bone densification in cases where you have abundant bone and you just want to improve the quality. If you have a thin ridge, okay, then you will do your pilot and you will expand. Immediate placements, of course, we all take out teeth and we place our implants. So in an immediate placement situation, again, you do your pilot, which can be done with rotation or with the VGO accessory tips, and then you proceed. All right. Krastev lifts, I won't talk about too much today. I'll just show one case because that's Krastev lifts is a whole other discussion, but I will say this. I don't like malleting osteotomes to break the sinus floor because we can have vertigo that's usually transient and goes away in a week or two, but it's not pleasant, okay? It's not pleasant when a patient comes in and says, I can't walk straight for the next week. It's not right, right? So what I do when I do Krastev lifts, I do a hybridized technique where I use one of the proprietary kits that are out there. There's very many of them for getting into the sinus with rotation. So once I get into the sinus with rotation and I verify membrane integrity, then I increase the diameter of the osteotomy with the VGO system, while at the same time I respect the working depth. In other words, I don't want to put the instrument past the working depth of the termination. And of course, one of the key things that I think is very important is we are avoiding any production of heat, folks, okay? Another thing that I find very rewarding in terms of patient comfort is there is no water in the patient's throat. Okay, so we're not choking the patient with blood and fluids and there is going all over the place. Once you make your pilot, it's a very clean, delicate procedure, and patients seem to report that it's a lot more pleasant than having a drill with rotation. Now, I personally have 2 implants in my mouth, and I had a lateral window sinus graft done. And I got to tell you guys, when they drill those osteotomies, you feel like they're going to come out of the other side of your head. It's not the best sensation. And very, very important, okay? I believe that we must always be able to control how fast or slowly we expand the bone based on what we want to do, and based on how much bone we have, and based on the bone density, okay? And unfortunately, now with the corona crisis, another very important benefit that I have realized, and I guess most of you will realize, is we are not creating aerosols. All right. So, I mean, this is the corona time is not a good time for anybody. And if we can do a little help to possibly decrease the chances of disease transmission, and you know what, God bless. So, couple of advantages. Anterior, we're not melting at all. Okay. We always have passive entrance to a certain point with the tips, and then the tips become activated and start dilating. Okay, and when you're using the instruments, you will actually feel as you screw them in by hand, the tip will actually talk to you and tell you, now I'm starting to dilate the bone, because you feel the resistance, okay, increasing. So because of the length of the shafts, we have an increased tactile sensation, number one. Number two, it's much easier to watch your angle. Okay. So let's talk about a couple of things. When we drill an osteotomy, we need cooling, and we accomplish cooling by using saline, but there's a lot of variables. The deeper an osteotomy is, okay, the cooling efficiency becomes decreased. Then we have to consider how sharp are the drills that we're drilling with. Sharp drills will cut with efficiency, and dull drills will overheat the bone, and they will essentially burnish the bone, okay? Speed of rotation, as we know, the faster we rotate, the more friction we create, the more heat we generate, right? So in many cases, we have to ask ourselves, do we want to drill in this case? Do we want to use an osteotome? Or do we want to hybridize? Okay, so each case should be really addressed on an individual basis. Oh, bone. Let's talk about bone a little bit. Bone has a lot of variation, all right? So our osteotomy technique should be selected based on the situation we have at hand. Right? So we have variable widths, heights, densities, angulations, morphology of the face, of the internal structures. And we have to sit down and ask ourselves, how much bone do we have? What do we want to do with it? And how are we going to get there? All right. So in my opinion, we need to get to the end result with the minimal amount of trauma. Okay. So in some cases, we have to maybe combine perhaps drilling and osteotomes. In some cases, we may avoid osteotomes altogether and just do it with a drill in cases where the bone is very dense, for example. Okay. So it's important to understand a concept, and I will briefly say, usually in 99.9% of cases, I use the the ZEF VGO mode, where you're following each tip sequentially, tip 0, tip 1, tip 2, until you get to the size that you desire, okay? But the VGO also has another mode of use called the hybrid mode, which is essentially using the same formula as this mode, okay? And the same benefits of the deep dilation, but you're leaving out certain tips. So in other words, when you do the ZEF mode, the bone is doing, I hope you guys can see my hands. When we use the ZEF mode, the osteotomy is being dilated this way, okay? This way. If we do use the ZEF hybrid mode, the osteotomy is doing this once the tips become active. And if you see on the right side here of the screen, it says traditional mode. So believe it or not, folks, the traditional mode of traditional taper osteotomes is a byproduct of the formula that we have created. I don't recommend this mode because this is the mode we're trying to run away from for reasons I will show momentarily, okay? But I have to mention it because this is a side effect of the formula, all right? So for all of you out there, and for the sake of this presentation, we're following the sequence of instruments, one after the other, all right? So here's a case where we have abundant bone, okay? It's a simple case because we have abundant bone. But in abundant bone, we may want to improve the bone quality. Okay, so this is a good case to learn on because there's not much that can go wrong. You do your pilot osteotomies, and you only will accomplish densification. Okay, so this is an easy slam dunk kind of case. So for beginners, this will be a great learning experience. Now, a more complex case may be a case that's a little more challenging. For example, when you do an immediate placement that will require some grafting. Okay, well, a case where you have some structures involved, perhaps roots that are slightly on the left-hand side here. You know, the room here is limited. All right. So this case I will go over in more detail in the presentation, but this is the first case ever done in the world with the VGO system before it was launched, and it was done with the first prototype that I received from Germany before they were actually finished, and you will see the tips in a few minutes. So once again, we have to structure in our minds the degree of difficulty and what's involved. All right, let's look at another one. So this case here has a couple of mistakes, which I'll point out. But this is a more difficult case. Why? Because in this particular case, it's narrower. So some grafting will be required after the implant is placed in the middle of the screen here. Okay. But in this case, I didn't anticipate to do grafting. So if you notice, I opened the flap without going one tooth over or two teeth over because I was not planning to graft. Okay. Because as we know, when we do grafts and we decorticate and we graft bone and put membranes or PRP or PRF membranes, whatever you guys use and whatever you call it, doesn't matter to me. But in those cases, when we're going to graft, we extend the flap. So this was a case that worked out beautifully. But if I'm doing it with the anticipation of grafting, I will certainly open a bigger flap. All right. So here on the left side, I'm showing the pilot hole was done. Usually I like to use rotation to do the pilot, at least to penetrate the cortical bone, because the cortical bone is always dense. So I don't want to hammer. Now, once I penetrate the cortical bone, I have two options. I can either continue the pilot osteotomy with rotation, which is perfectly fine, or you can use the VGO accessory tip, which will do the pilot with some light malleting. While you do that, you will feel how dense the bone is. So when you do it by hand, you get some indication as to what's inside. All right. And of course, I'm showing the final implant, but we'll go through this case in a little bit more detail in a bit. So depending on the situation and what type of bone you're dealing with, the bone will respond differently. Okay. In this case here, it looks like it's almost like I split it, but this was no splits. There's no vertical cuts. This all was done exactly as I've been saying, since we started, pilot and then VGO and then the implants placed. But look how the bone starts to expand and bulk out. Okay. Now, this will not happen in every case. This depends what kind of response you will get. It largely depends on how thick the cortical shell is, how dense or soft the bone is inside. So there's a lot of variables. So in many cases, you will see different responses. This is another one, just showing the osteotomy being completed. And take a look here, folks. Okay, you see how this came out, how it got displaced? And here I'm just showing a blow up of it. All right, so here I'm using, again, if you notice, the instruments here are they're not finished yet. They don't have the surface finish, etc., in the labeling. So this was done with the prototypes, and here I'm showing again what's going on with the buccal plate as you expand. And of course, on the right-hand side here, I'm showing you the finished instruments with the proper labeling, etc. And this is to understand the concept fully takes several hours and a much longer lecture. So today we're going to be sort of hitting some of the highlights. So when we do our osteotomies, folks, we usually focus our attention on the buccal and lingual aspect. Why? Because that's usually where we have to deal with issues of how much bone availability we have with. Okay. What I highly recommend, always start your pilot osteotomy slightly to the lingual. Why? Because the lingual plate is always more dense. So whether you're drilling or using osteotomes doesn't matter. But when you start a little bit to the lingual, as you proceed to increase the osteotomy, it tends to move you to the buccal slightly, all right? So by the time it's done, you're in the middle. Okay, now this is a very important slide, and I want to spend a few minutes here. So if you notice here, the VGO tip is inserted to the 8 millimeter point, okay? And then the tip becomes active. So I call this term passive engagement. So passive engagement means the tip will go into a particular depth until the threads disappear, and then the dilation starts to occur, okay? So we're not spreading anything here at the crest until the instrument's going. So the VGO operates on this premise, passive engagement. That's the big advantage, guys. Now, conventional osteotomes, look at the middle of the screen. Conventional osteotomes function a principle that I call passive active engagement. And passive active engagement means that the minute the tip touches the crest, the dilation starts, okay? So when you go to the next instrument, the same thing happens. Dilation starts immediately at the crest, but the crest is usually the thinnest, and that's when it starts to flake off. So this occurs whenever you are using traditional osteotomes or dilators to the full working depth of the tip. So the next tip will do the same thing. But what happens when you're using traditional osteotomes to less than their full working tip portion? For example, when you're placing a 10 millimeter implant and the max working depth of an osteotome is 16. So if you're doing a 10 millimeter implant, okay, you're not using the full depth of the traditional osteotome, and you end up in a situation now that's on the right side of the screen. So whenever you use traditional osteotomes with traditional Summers taper, okay, and you don't use them to full depth, this is what happens, folks. You start trying to have a situation where you're trying to shove something bigger, which I said earlier, into a hole which is smaller. And I call that non-engagement. That's a boo-boo. It's a no-no, because this only can damage and crush the bone, okay? So here I'm just showing it in a little more detail, and I'm saying best. Why? Because the hinge axis here of rotation of the bone is moved into the deeper bone before we start pushing it out, okay? When you're using traditional osteotomes, again, it's okay, but you start to apply all the pressure immediately at the crest when you go to full depth. That's very important for you guys to understand. And maybe perhaps you guys can sometimes draw a picture of osteotomes and think about what I'm showing you. All right. So both our anterior and posterior kits feature 2 accessory tips. And these accessory tips, as I said, can be used to create your purchase point. Especially, they are very useful when you do immediate placement, because during immediate placement, what happens is we usually like to engage the lingual plate, all right? So in my experience, I've noted over the years that whenever you try to drill in here, the drill has a tendency to slip and slide and go and not end up where you want it to end up. So that's why we've introduced the curved tip that you could essentially hit with the mallet once or twice to mark your position and to start the osteotomy. Then you can drill into it with rotation, or you can use the straight tip of the VGO accessory tip to do the pilot, all right? So again, here I'm just showing a diagram of typically we want to engage the lingual, okay? And create our purchase point before we actually proceed. So as I said, the entire system consists of Delta 1 and Delta 2 tips, and they are complete opposites to one another, folks. So, you know, men and women, we are opposite. Salt and pepper, opposite. North Pole, South Pole, men and women, Delta 1, Delta 2. So Delta 1 and Delta 2 work at opposite poles. Okay, so let's talk about very briefly here. Delta 1 tips will dilate the deep bone, as I said earlier. How do you know which one is what? Well, if you subtract the taper, you know, from the base, from the apex of each tip, you end up either with a 1 or a 2. So if you have a 1-3 instrument, 3 minus 1 equals to 2. So that instrument will be immediately a Delta 2 instrument. If you have a 1-2 instrument in your hand, 2 minus 1 equals to 1. So now you immediately know whether you're dealing with a Delta 1 instrument or a Delta 2 instrument, all right? The other way you can do it is because they're labeled with the dot below or above the instrument number. Okay, Delta 1 tips, because I said to you earlier, they have less taper, okay? They have an tipex, and less caution is needed because they have half the taper of these guys. So these guys, the Delta 2s, have a bigger taper, okay, and they are the odd number tips. So, and I put these two little figures. These are Bulgarian figurines from the holiday we have in Bulgaria. And I say Delta 2 tips are sexier, okay? They're a little more curvy, a little more voluptuous, let's call them. Okay, so the basic premise is this. Pilot osteotomy is done, and then you start and you follow the sequence, okay? Delta 1 instrument will dilate in here and not do anything here, okay? The following tip will start to spread here, but not directly at the thin portion, but rather, as you see right here in this screen, okay? So it's a progressive, once the tip becomes activated, the progression starts to become, as you proceed deeper, it's active. So initial osteotomy, lens drill, implant drill, whatever is convenient for you, okay? Delta 1, tip action, spreads the deep bone. Make the deep bone more flexible before you introduce the next tip, which will spread the crest, okay? And here I'm just showing, again, a diagram showing how Delta 1 versus Delta 2 tips have different poles of action in different portions of the osteotomy. In this slide here, folks, I'm just showing you, let's talk about, let's focus on the first two tips, okay? So this is the posterior kit. The posterior kit starts with the first instrument in the posterior kit is labeled instrument number 1. And it has a 1-3 taper. Okay, so 3 minus 1 equals to 2. So right away we know this is a Delta 2 instrument. Okay. The next instrument is a 3-2 taper. 3 minus 2 equals to what? 1. So this is a Delta 1 instrument. It's sort of very logical. So now, if you made a hole with this instrument and you have a residual hole left that has a 1-3 taper, and then you introduce the next instrument, which is this guy here. Well, the cross-sectional diameter here at the tip is 2 millimeters. The cross-sectional diameter of the hole residually left by the previous instrument is 3. So this enters freely, okay, in here. Oops, I went back. I'm progressing too quick. Okay, so this enters freely. I lost my mouse. Okay, sorry, guys. Enters freely and then becomes active at a certain point. Then let's look at the next one. We have a residual hole left here that's 2 and 3, and the next instrument is a 2-4. So the 2 will freely go into this hole and become active when this tip reaches a certain point. And here I'm showing exactly what I was saying a second ago. At what point does that tip become active? Once you go into 8 millimeters in, all right? The next tip will go into the osteotomy and again until the 8 millimeters in, but become active at a different part of the osteotomy, namely the crest. Okay. And here I'm showing a superimposition of the passive entrance, okay, with the green arrows, and I'm showing at what point each tip becomes active. This, folks, applies to the anterior kit and the posterior kit, okay? And this is the accessory tip. So again, you can do your pilot with rotation if you wish. You can do it with the VGO accessory tip if you wish. It's your choice. And basically, you're following the sequence. So typically, I will go from tip 0, tip 1, tip 2, tip 3, and so forth until I reach my final osteotomy diameter. Okay. And here I'm just showing the tips being threaded into the bone and doing the expansion. All right. And there is an osteotomy completed. Okay, so let's go over in a little more detail the first case in the world I've ever done. This case is interesting. So I got the first kit, and I wasn't supposed to use it because it wasn't finished and it wasn't surface hardened. But of course, my wife's grandmother broke her tooth, and she came in, and I decided I'm gonna do the first case on her. And you know, we love her dearly, and you know, we played. Okay, so we took the tooth out. If you notice, I engaged the lingual aspect and did my osteotomy. Here I'm showing the pilot osteotomy done, and here I'm showing the incisive canal. All right. In this particular case, I have a probe stuck inside the incisive canal to show me the angle. All right. So if you notice, the implant is placed lingually. Okay, and we have this void. Now we know from the literature that this void is bigger than 2 millimeters, less than 2 millimeters. This happens, that happens. Well, you know what? I'm the kind of guy I graft everything. I don't leave this kind of voids to fill in on their own. I graft everything. And of course, here I'm showing the graft in place. Here is the implant placed. And this was a 3.7 by 1360, guys. All right, here I'm just showing the transfer component. I like to always take an X-ray with my transfer to verify it's seated properly. Okay, and these days I'm starting to go to more and more of the zirconia abutments, but anyway, that's another discussion. And of course, here's the final prosthesis, and here's the final result, and there is the implant restored. On this one here, we have a little open margin. If you guys know that, things like this really should be avoided. And I think this is my implant also, so that's a little boo-boo I missed here, a little open margin. But as we know, this is not an implant, and it's still an issue with bacteria, etc. But it's not as critical as if this was a tooth. This case was very interesting. This was a young woman who presented without history of any trauma, without any falls, without any hits, without any accidents. And if you see the damage she has on the right side of her face here, okay, and no one can figure out why. The rest of her mouth is pretty sound, okay. She definitely had some perio issues, but a lot of destruction and teeth falling out of her mouth, and nobody can figure out why. All right, so in her case, we did 2 implants. Here we show the flap being opened. Okay, so this is the, let's go, flap reflection. Pilot osteotomy slightly offset to the lingual here, okay. I did a suture here to retract the flap just for show purposes, to make it a little bit easier for access and a little bit easier for me during the procedure, and also so I can show you guys better photos. Here I'm showing, I like to always take a pilot X-ray, whether it's with the VGO first tip or whether it's with a pilot the drill that you've used. I like to see a pilot X-ray to see the angulation, okay? So in this case, I've inserted the tip 0, which is the 1-2 millimeter taper, and I took an X-ray. And then the next tip proceeds, tip 1, which is the 1 millimeter, 3 millimeter taper. So densification is being done with full control of how fast or how slowly we're getting there. And while we're doing this, we're not generating any heat, all right? I like to minimize heat. I'm obsessed with avoiding heat. Here I'm showing you guys the final osteotomy, okay? Not the palatal offset. Here I'm just going to insert my implant, and I always mention this is very important. Whenever you guys place your implants, please always check the speed settings on your handpieces, because the last thing you want is to go in at 800 RPMs or 1,000 RPMs or whatever speed you use when you place your implant. So double check, please, the speed and then place your implant. And here, of course, I'm placing my implant. I drive it down. This particular system is designed to torque out right about there, and the rest is done by hand. Now, very important, guys. If your implant torques out too early, please do not force it, because you'll break a neck. In my career, I've only broken 2 implants, and some of you will say, well, that means I don't do enough implants. I probably don't do half as many as you guys do. You guys are big clinicians, big surgeons out there. I'm a GP, so, I do a substantial amount of implants, but maybe not as many as some of you out there. But what I'm saying is I don't like to crack necks, and the 2 times I broke a neck wasn't very pleasant, okay? And again, here I show the final placement. All right, there's your implant, and in this case, I'm using my PRP membrane, and essentially doing a little poncho and closing it up. So then we move to the tooth number 5 site in the same patient, okay? Again, I do my pilot. I sutured up this area, pilot, X-ray, final osteotomy. And now, here's a little trick. When you think your osteotomy is completed, take the drill, the final drill that you have from your implant system, and try to place it into the osteotomy. See how it goes. Is it really, you're not able to get it in? Is it getting in? You have to kind of gauge what size implant you're using and open the osteotomy relative to the size of implant that you're using, okay? So this is a little bit of a trick that I've concocted in using. Okay, once again, we place our implant. There it is, and now both implants are visible in the same case. This tooth, needless to say, came out. And here is the PRF membranes. So this was a rather interesting case. This was done 8 years ago. definitely a Perio case, all right? Big time Perio case. Clearly, we all know and agree, I'm sure, that this really needs to come out, okay? And has no business. But, you know, some of my patients, they tell me, Doc, I understand the situation. I understand that this tooth has to go. I understand I have problems, but I don't want to do anything right now. I want to keep my tooth because I'm functioning with it and it doesn't bother me. So in this particular case, the patient had severe recession. So although this looks horrible, it was actually a stable tissue, no suppuration. So we, at the patient request, kept it indefinitely. But regardless, this implant lasted 8 years, and then it failed. All right. So here I'm showing the correction that we did, and we're going to go through it right now. And we did a Krastev lift, and then we replaced it with another implant, and there is the Krastev lift being shown. Let's look at more detail. This is the I put a short, fat, real fat monster. I don't remember the size, but this was a, I don't know, 6.5, 6.0 by 10, 8. It's a big implant, all right, big boy. So when I do the Krastev lifts, I hybridize. As I said, I don't like to upfracture the sinus floor with osteotomes because I want to avoid malleting, okay? If some of you want to do it that way and do it that way, God bless you, keep doing it your way if it works for you. But I like to use rotation, a rotation kit. Any one of your choice is up to you, whatever you guys use. And then I go to the VGO to make the diameter of the hole bigger while I stay shy of the working length. In other words, I don't want that osteotome going into the sinus. Once you start putting your PRP components or PRF components into the sinus for security, if that's what you use, then if you put the instrument slightly past the working length, no damage will occur because already the membrane elevation is starting, okay? But again, I recommend for people that are beginning these procedures to pick cases that are safer to practice on. All right, so in most cases, when I do a Krastev lift, okay, 75% of cases, I get into the sinus with rotation, and then I place my bone or whatever I place inside, PRP or not, okay, it's up to you, collagen membranes or whatever, yeah, that's the whole other discussion. But in most cases, I don't even use the osteotomes because it may not be necessary. But if I detect that the density of the osteotomy is poor, then once I enter the sinus with the rotation, then I go to these guys and make the diameter of the osteotomy wider while I accomplish densification. All right, a very quick review of the past. So years ago, we used to do Krastev lifts in 2 ways. Direct up fracture with an osteotome or a bone cushion technique where you, basically this technique involves drilling shy of the floor 1 millimeter or 2 with rotation, and then using an osteotome to up fracture the floor. And then you check your membrane integrity, you pack your bone, okay? But it involves a lot of malleting. I don't like malleting. Transient vertigo is something I like to avoid, all right? So excessive hammering, I like to avoid. Not my cup of tea, not good for the bone. It causes trauma and it can damage the bone, all right? So we want to minimize the hammering, which is accomplished with the VGO. And now let's look at the plan in this particular case. So this was the same case that failed. All right, folks. So here's the CT after I grafted. Here's the plan. So again, let's go through this. I did my osteotomy with a rotational kit. Okay. I checked for membrane integrity. Membrane's intact. I expanded the size of the diameter here with the VGO. Then I put my PRP gel inside. Okay. This, folks, will repair membranes very often, and it will give you insurance if you decide to place bone, which I did in this case after this was placed inside. This will assure you insurance with the procedure. All right. So this is these days. I started using PRP probably in the last year or so. Okay. So this is relatively new to me. And I'm using it more and more these days. So a lot of my cases that are older did not involve PRP. All right, so VGO posterior kit we talked about. We'll skip the slide. And here I'm just showing, again, my PRP membrane or PRPM, or again, I don't want to get into a discussion of who calls it what these days. There's a lot of confusion out there, but, you know, so PRP, PRF, I'm using it, okay? Here it goes. And here, again, we're positioning our membrane, and we close it up, and there is the sinus lift, and there's the implant. Let's look at a couple of pointers for beginners. So for beginners, when you're doing a Krastev lift, find a case that's easy to do. A case that's easy to do has wider bone, okay, and perhaps has 8 to 10 millimeters of available bone. Because if you have a case that you only have 5 millimeters of available bone, it becomes more difficult if you have a tear. How do you manage it, right? How do you stabilize the implant? So when you have 10 or 8 millimeters, there's not much that can go wrong. You can still put your implant a millimeter or two into the sinus with nothing, with a rib membrane, and it'll work fine, okay? But if you're starting with 5 millimeters of bone for the younger guys, and then you have a tear, then you have to know how to handle it. Either you have to open a lateral window, repair it. You know, it's a little bit more complex. And here I just want to mention one important thing. I like to work sitting down, okay? So whenever I do this kind of procedures, and here I'm showing actually a prototype I was creating with chopsticks. These are actually instruments made out of chopsticks here. And I took an X-ray just to show a point. When I do a Krastev lift, I like to detach my membrane. I like to walk it all around the wall, sliding it. Okay, very often I also use hydraulic lifting. Okay, so I inject saline to detach the membrane before I introduce anything into the sinus. All right, and it's important that throughout the Krastev lift procedure that you are constantly checking for membrane integrity. Okay, I don't want to shove things into the sinus and have it spill all over the place and possibly to blocking the osteum and sinusitis and the complications that can occur. All right. So one thing, gravity. Gravity, when a patient is laying down, will have a tendency to push the bone towards the back. As you see clearly here, there's a lot more bone back there, okay, here, in comparison to the mesial aspect. So this was a very interesting case. And let's talk about this for a minute. This case I started, it's a full mouth rehab case. I put some temps here and there. I did not have a CT on this case yet, but let's focus our attention here because this is important. Okay. So let me go back to the next one. Oh, jeez. Sorry, guys. Okay. So let's focus on this X-ray here. All right. I don't see any pathology here. Maybe a little shadow here, but it looks like a slam dunk case. I saw this. I said, I'm going to be done in 10 minutes. I'm out of here. Easy slam dunk case. Boom, boom, boom. We'll finish quick. Well, let's see what happened. So I open the flap. I start cleaning. I take out the roots. And I start looking at a hole damage in here that this thing was getting to be big enough that you can shortly stick a camera in there and look around. Okay. Extensive pathology was cleaned out. Okay, so now I'm looking at the final hole cleaned out from granulation, tissue, and junk. And I'm saying to myself, Pavel, you're going to graft this case, and you're going to come back in, and it's going to be there at the end of it. You do a staged approach, all right? Graft, then implant. Then I started thinking, I said, let me try something new. So what I did, I said to myself, can I do something here and graft and use one of the kits and essentially place my implant directly at the same time I do the graft? And that's exactly what I did. So I cleaned out the infection. I packed it with my sticky bone, gummy bone, okay? And then I was going to use the posterior kit because it doesn't have threads to create the hole in the grafted bone. So in other words, I did not wait for this bone to turn over and heal. This is being done the same day as I grafted that big defect, okay? I decided to go with the anterior kit. I placed my graft material and I placed my implant at the same time into the hole I just showed you, all right? So this is not a delayed approach. This is same day. And then, of course, in this case, I closed it up with cytoplast and a mattress suture. Of course, if I'm doing this today, I wouldn't use cytoplast. I would use my PRPM here, okay? And the closure. I was going to insert a video here to show you the second stage surgery of this exact case I just did, that I just showed you. But I put it up on my timeline yesterday for the benefit of time. And I don't want to severely run over time. So that video is up yesterday on my timeline. I wanted to prep you guys for today, and you're more than welcome to go and see it, okay? Let's look at another case. So this is a nuisance, a little bit of a problem that occurred that can occur now. That's why I like to always show this case. So I did my pilot. I was off angle. I corrected it. I proceeded with the VGO tip, placed my implant a little bit off the angle, okay? But I want you to focus here, all right? So what happens here? The healing, okay, let's go forward. The healing screw became loose. If you notice that seam, this happened in a month. This thing was buried, okay? It was under the soft tissue. Patient comes in a month later. I see this and I see bone loss. I open it up and this is what I find. So this is why, folks, it's extremely important for all of us to monitor our cases as they integrate, as the implants are in their healing phase, because things happen, and if we catch them early, we can correct the problem, okay? Because bacteria starts to do this, okay? So what did I do? I cleaned this up. I cleaned it up. I didn't use any membranes. I grafted the defect. I put my second stage healing above in here, okay? Closed it up. This is just another case. Here I'm using another system. A little bit limited mesiodistal space, a little bit, limited here. This is way past the pilot drill. This is probably the second drill of the system. Then I switched over to the VGO. So in other words, you can go from rotation to the VGO at any time if you decide to. You don't necessarily have to start just with the pilot. You could do your osteotomy halfway drilling and then go to the VGO. There's no rules, okay? And once you understand how it works, you can play around with it a bit. And here, of course, I'm showing both implants placed. So following the placement of the first implant, I put a transfer in here or some kind of screw or whatever you have available, just to guide me with the angulation as I do the osteotomy in the second site, okay? It's all about access now. That's an important point. So the VGO system is designed for the anterior, but I use it in premolars routinely because I have access with no problem in the premolar region. In some cases, I even use the threaded tips in the first molar region whenever I have access. So it's a question of access, how much your patient can open, how much they cannot open. So that's how we have to modify our technique. And here I'm just showing the implants being driven in. Okay, so a little surprise. Oh, we're coming towards the end. So small surprises coming up. For those of you that are interested, the Helmut Zeff has a USA dealer called H&H Company, okay, and they are licensed to carry the product. And Helmut Zeff has global licensing rights to produce, manufacture, and market the VGO system, as well as my other products. But H&H is the company that carries it currently in the USA. And a small surprise. Yesterday, Mr. Heinz Leben from Helmut Zeff said, Pavel, let's do something special. And let's do something in honor of Global Summits and Dr. Keanu Shar and Dr. Kayvan, and of course for me. He said, let's offer everyone interested a 15% discount for 2 weeks. So anybody calls H&H, they will know about it. It will be arranged that everyone will receive the 15% discount. And Helmut Zeff from Germany is offering this courtesy for 2 weeks. Again, to thank all of us and to just do a nice thing for all of us. All right, guys? So I thank you. It's been a pleasure. And what can I say? I'm deeply humbled and honored that I had this opportunity to spend with you guys. And stay safe, be well, and I guess we'll take questions.
Very good. Thank you so much, Doctor. That's quite a nice gesture from you and Helmut Zeff. And we are very honored to have this today with us. So tell us a little bit. I have one question here. Why didn't you cover the areas with CTG?
CTG. So again, now we're getting into the hold on, CTG. Hold on. Give me the abbreviation because I'm having a brain fart right now. The CTG is the platelet stuff. No, is that what you're referring to?
Yeah.
Oh, connective tissue graft you're talking about. Okay. I myself don't do connective tissue grafts. I'm not a periodontist. Hold on. Am I supposed to be seeing a screen, by the way, here? Because I see a black screen now.
No, it's you should be just seeing yourself.
I don't see anything. Anyway, should I keep talking or?
Yeah, you can see you.
Yeah. Okay. So I don't do connective tissue grafting. It's something that I'd like to learn. I have no experience doing it as much as I should have. So connective tissue grafting is not much in my armamentarium at this point. In most of my cases, whenever it's recommended or required, I usually refer to a periodontist.
So, Dr. Pavel,
Yes,
when you're actually using the osteotomy instruments, are you able to have a better handle on angulation for post prosthetic restoration?
Wait, say that again about the end, the last part.
Are you able to plan for your angulation, the angulation of the prosthetic after that? Does that help you that you have a long lever that you can
Absolutely. Well, look, that's a great question. In the anterior, okay, we know that usually anterior teeth are, have their roots placed much to the buccal, okay? So if we, in many cases, unless we do extensive bone grafting, it's very difficult to place the implant in an ideal position buccolingually because of the anatomy. So if we took a case where the implant has to require a custom abutment, you can avoid using a custom abutment if you grafted everything. But who wants to have an additional graft procedure added on? So in my office, I use custom abutments very often to cheat a little bit and help me when the angle is off. However, using the VGO, because of the length of the handles, I note and I find in my hands, the angulation is easier to control and engage. When you're drilling, I find it's a little more difficult. Did I answer your question correctly?
Yeah, I mean, I like using the shafts of drills and things of that sort to kind of orient my to envision and visualize the final prosthetic and work backwards from there if I'm not using a guide.
Right.
So I would just imagine that if you have that in your hand and you're preparing the site, be it for press fit or any other kind of scenario, you're going to have a better angulation than you would otherwise. Is that correct?
I would tend to agree with that. Yes, yes. But again, this is a whole conversation, because are you planning a screw retain case, a cement retain case, and we know if you're doing a screw retain case, then the angle should be a little different because we're shooting for a different positioning slightly of the implant. So it all has to do with the planning. I personally don't do too many guided cases in my office. I mean, it's not really my cup of tea. I think it's great. I think guided surgery is wonderful, but I think it adds very often extra expenses. So when do I use guided surgery? If I'm doing a full mouth case, yes, I would love to use a guided case. But when I'm doing single implants, 2 implants, 3 implants, I can't remember the last time I used the guide. But again, I repeat, doing guided, if patients can incur the extra cost and they don't mind, I think it's a great way to go. I mean, it's definitely a safer way to go, especially for people that are beginning. But in my practice, I don't do guided every day. It's very rare that I go guided.
Wonderful. Wonderful. Yes, there's always a debate with guys, as you know, I'm sure.
Yeah. Any other questions we can entertain?
I have no other questions unless someone wants to come in. It's all great compliments about the wonderful deed you have done. And sometimes when we try to achieve something grand together, there are always challenges and there are always forces that prevent that from happening. But today we stand tall with over 800,000 of our colleagues who have been supplied limitless information for knowledge and something they can use to help hundreds of millions of patients, that we have over 150 dentists that work either around the clock or have participated in some capacity or another to make this happen for our colleagues. So with that said, we are on a noble mission to achieve our goals, and we really look forward to your support and the support of our countless doctors that have stepped up for the mission to utilize our time wisely during this pandemic. And peer-to-peer works, and it's one of the many projects that's currently in the making. I have one more coming in if you have time.
Yes, sure. By the way, I just want to comment. I mean, we're proud to be part of the organization and to go ahead. I'm sorry. Go ahead.
Yeah, go ahead. Please tell us your beautiful words.
No, I was just saying that we're honored to be a part of this gigantic event that you're operating and sharing with the world. And, you know, the small that we can do, we're behind you, and we look forward to being a part of it and growing together and hopefully sharing many more webinars with the public and with our friends. And, you know, let's keep dentistry united and let's keep rocking. What can we do? We're a big family.
That's our tagline, united we will stand. Wonderful. So the last question of the day before I let you go, and thank you so much for your time, is in the case with the Krastev, here, I'll put it up for you so you can take a look at it yourself.
Sure.
In case with the Krastev resorption after the implantation in the premolar area, you said you cleaned it. How and what bone substitute material did you use to fix the problem?
If I remember correctly, that case I cleaned manually with curettes. And if I remember correctly, I'm 99.9% sure I used the irradiated cancellous bone in that case with no membranes. And if I remember correctly, I only irrigated it with flagell liquid, okay, flagell solution, nothing else.
Excellent.
And no membrane.
Wonderful. Glad to hear that we have given them a response. Again, thank you for the big surprise today and your efforts and contribution to this peer-to-peer project.
My pleasure. Love you guys all. Thank you.
Thank you. Take care.
Bye-bye.